Hello everyone, welcome to this evening's Lecture of Distinction, where we'll be discussing a very important topic, the safe management of the acute diabetic foot. The reason why today's topic is so important is because the consequences of an infected diabetic foot ulcer can be severe. Over 135 patients a week undergo amputation, and up to 80% of those patients will die within 5 years. This is why the safe management of the acute diabetic foot is a core skill expected of all orthopedic surgeons and is therefore regularly asked in the FRCS Viva. So for that reason, that's a good reason to listen in. My name is Hiro Tanaka and I'll be your moderator today. Our webinars are now sponsored, which allows BOFAS to continue producing high quality education. So for this evening, I'd like to welcome the support of LEADER and OrthoLove, and here are a few words from them before we start.
You spend years of orthopaedic training to become masters of surgery. Do you want your surgery to be compromised by poor post-operative pillow elevation? There is another way. OrthoLove elevators can be used before, during and after ankle surgery to help contribute to a better outcome. Before surgery, get the patient swelling down and speed up time to theatres. During surgery, ditch the upside down kidney dish and use the OrthoLove foot holder to keep the limb in the correct position throughout your case. After surgery, cradle the limb with comfort and stability above the level of the heart to reduce post-operative swelling, enhance wound healing, and soft tissue recovery. But what about when the patient goes home? OrthoLove home foam elevators are beautifully designed and much loved by our patients. Celebrities and professional sports stars all raving about us on social media. OrthoLove is proud to support the BOFAS commitment to training and education.
Right, so for this session today, please submit questions using the Q&A icon at the bottom of your screens, but please be aware that questions are asked on a first-come, first-served basis, and we rarely have time to answer all of them. So for today, we're privileged to have as our speaker, Fred Robinson, who is one of the national kings of diabetic foot care. He's a consultant in Addenbrooke's in Cambridge. He's an ex-president of BOFAS and a council member of the BOA. In 2015, he brought together BOFAS, the BOA, Diabetes UK, and the Vascular Society to promote multidisciplinary care, which is now regarded as best practice guidance and is downloadable on the BOFAS and the BOA website. He is a true inspiration, and the Cambridge model of diabetic foot care is recognized as amongst the best in the country. So thank you for joining us today, Fred.
Good evening, everybody. Thank you very much indeed for that very kind introduction, Hiro. Hang on. I think, is that sharing?
Yes, it is.
Yeah, okay. So I've been asked to talk about the diabetic foot attack, and the acute care of the diabetic foot is absolutely crucial. As Hiro's outlined, this is a major problem for health. So really what we're talking about is the red, hot, swollen foot. Now the differential obviously of that is wide, but the things we're really talking about today are abscesses, cellulitis, early Charcot. So those are the things that we really need to be clear about and to understand that we're treating. And really only one of these has an acute indication for surgery, which is applicable to everybody, and that's the abscess. I cannot emphasize enough how important it is that we get on and treat these patients with an abscess quickly. This is not something you can say, oh, well, the foot guy's back on Monday, and tuck the patient up in bed and wait for 48, 72 hours. This should be in everybody's armamentarium. I don't think anybody has too much doubt about draining a thigh abscess, but everybody has concerns about the diabetic foot. And that concern is completely understandable. So I'm going to go through some of the basic principles and hopefully take it forward as to why you don't need to be scared and why actually you can get on and save this patient's limb and maybe their life. Pus needs urgent drainage, maybe a better title for this talk than the acute foot attack. This is where everybody in this meeting, everybody going forward has come into it. And Matt Salan and myself introduced a critical case-based discussion about 5 or 6 years ago into the FRCS curriculum. So this is crucial. It's core knowledge that you must know and understand. So I think one of the things we have to understand is that the diabetic foot is a manifestation of diabetes, which is just spiraling out of control. And obviously COVID has drawn obesity. The crisis has drawn the illness of these patients to our attention. But this has been going on for years. Now that 972 million to 1.13 billion is not the cost of diabetes, that's the cost of the diabetic foot. So this is a hugely expensive problem. It uses approximately 1% of the total NHS budget. 25% of all diabetic admissions are for the foot. 8 per 10,000 require above ankle, and 18 out of 10,000 require below ankle minor amputations a year. So this is a huge problem with huge mortality and huge morbidity. It is something that is progressing, it's getting more common, and not something we can afford to ignore. We ignore it at our peril. We need to be engaged, and going forward, it's going to be interesting to see what comes out of the crisis that's going on within healthcare. But this is not something that's going to go away. It is something that's going to become more, without doubt, more common, and something that is going to require our attendance. If you don't treat it acutely, you generate a worse problem that is more difficult to treat, causes more problems. So this is crucial. So why do these patients get problems with their feet? Well, whenever I see a patient, it is remarkable how infrequently the arterial status and the neurological status of that patient is recorded in the notes. So the note reads, patient admitted with a diabetic ulcer over the weekend, ask Fred to have a look on Monday. Does anybody write in the vascular evaluation? Does anybody write in the neurological evaluation? Often not. We know that arteriosclerosis is commoner, occurs earlier, is more diffuse, more distal, and progresses more quickly in the diabetic. We know that these patients have neuropathy and that neuropathic feet ulcerate. It is virtually impossible to ulcerate a vascularly normal and neuropathically normal foot. So if patients have pure rheumatoid with no vascular disease and neuropathy, almost none of them ulcerate despite their massive deformity. The patients also have some degree of deformity. So the glycosylation of the collagen leads to contractures and so on and so forth. So these patients have all of these factors which go on to lead or predispose them to this problem. So when you see them, grab a Semmes-Weinstein monofilament. So you'll see the white plastic bit you hold, and then there's a bit of fishing line on the end. And the crucial one is the 10-gram Semmes-Weinstein monofilament. And what you do is you put the monofilament on the skin and you deform, so you bend the fiber. And if the patient can feel that fiber, they have sensation. And it's virtually unheard of for a patient who can feel a 10-gram Semmes-Weinstein monofilament to develop Charcot or to develop neuropathy. This is a really good screening test for sensation. The other critical thing is the presence of pulses. And if a patient has a dorsalis pedis, they have a 96% chance of not having a vascular problem. Now, it can be very difficult to feel a dorsalis pedis with swelling or pain or whatever the patients have when they present. But if you can feel that dorsalis pedis, you don't have a vascular problem to all senses, really. So make sure you examine the sensation and you examine the pulses when you first see the patients. You can go on and do clever things. You can look at ankle brachial pressure indices, but these patients have calcified arteries. And often when you're operating on a diabetic in extremis, you put the tourniquet on and you end up with a venous tourniquet. And that's a manifestation of how hard their arteries are. So you can get falsely elevated ABPIs. Toe pressures can be useful and transcutaneous oxygen can be useful, but those are specialist and really only available to the vascular surgeons. But they are things I use in my practice to determine later reconstruction, but not so much acutely. So foot ulcers may occur in the hindfoot. They may get a tendon or bone. The majority are present with a neuropathy, and about a third of them have an ischemic element. I think the more severe ones have a much higher ischemic element, actually. And when I started doing this 20 years ago, ischemia was rarer, but we're getting so good at keeping these patients alive, ischemia is now much commoner. So here we go, here are some ulcers. So I think you've got to think about this. So you're called to see the patient on call, look at what the problem is. So these are both red inflamed feet. So the foot on the left with the ulcer under the third metatarsal head has a high arch and has pressure under the third metatarsal head. An ulceration is really just a manifestation of high pressure with reduced sensation and reduced vascularity. So you'll see that patient has an ulcer under his third metatarsal head. It looks relatively superficial and didn't probe deep to bone. So that is from walking on it in inappropriate shoes. Now, if you look at the patient on the right-hand side with the ulcer over the tip of his fifth toe, there's some pus there, it's slightly necrotic, but obviously that has a different etiology. That ulcer is caused by rubbing of the toe on the toe box. So you need to think about how this ulcer occurred and what happened. You also need to look at the depth of the ulcer. So Grayson in the Journal of American Medical Association about 25 years ago, he put a metal probe in. If you put a metal probe in, you should all have one with your Semmes-Weinstein monofilament, certainly the podiatrists carry them around. If you can probe to bone, there is a high possibility of osteomyelitis. And the presence of osteomyelitis means that surgical intervention is more likely. About 50% of osteomyelitis in diabetics will settle down with antibiotics and be cured by antibiotics, but not all. And it may be that actually, if you can't, the real value of this test is that if you can't probe to bone, you're almost inevitably not going to have osteomyelitis. So this basic assessment, clinical assessment, tells you so much. Here's a patient not with a red acute foot, but early on in the disease. And you can see this is a patient who may go on to develop problems. He's got hemosiderin, the brown staining underneath the skin. And that's a manifestation of microtrauma and may well lead to later ulceration. So this patient needs appropriate shoes, they need good chiropody care and avoidance. And I think one of the important things about this is, as Hiro said, I produced a document a few years ago in association with many others, and it's the structure. So this is not something you can do yourself. It needs podiatrists, it needs diabetologists, it needs vascular surgeons, microbiologists. So this is classic MDT type work. But the problem is when you're the on-call registrar at 8 o'clock on Friday evening, you are not going to have access to all of those experts. So hopefully what we can do a little bit in this lecture is take the fear out of this condition and help you to establish some basic principles. So all you need to determine is which patient you need to drain the pus and how to do that most safely. Here's a patient who I inherited when I was first appointed. He worked on the roads. He's obviously got a large ulcer which has been present for many months, and you can actually see the fifth metatarsal there. Now we'll see his X-ray later, but here you have chronic osteomyelitis. So in this sort of patient, you can see he's got changes from venous disease. And you've got to decide, has the patient got some simple osteomyelitis? If they've got osteomyelitis, there's no great hurry to do anything as long as they're systemically well, and the majority will be. It's the patient who has the red, hot, swollen foot, has a swinging fever, high CRP, and generally looks a bit uncomfortable and flushed and unwell. They're the ones you need to worry about, and those are the patients who need acute surgical care. This sort of patient can wait till after the weekend. They may need some suppressive antibiotics over the weekend, but one's got time to determine how best to cure their infection. This is a slightly different thing. So this is a grade 4 ulcer. So Wagner and Meggitt graded ulcers, and the grade 4 and grade 5 reflect ischemia. And we'll look a little bit at Brodsky's classification, which is a modification of this. But here you've got obvious ischemia, obvious necrosis. This patient will be sick. They need proper evaluation. They're probably going to have vascular disease. And ideally, you need to have your vascular surgeons help you with the assessment of this. This may be an acute problem, but it's not as bad as when you've got hindfoot ulceration, where the patients are often in a real pickle, potentially with gas, gangrene, and infection. So this patient has got a red, hot, swollen foot with the obvious gangrene of the toes. Hopefully they won't be systemically unwell, but they may well be. And they're obviously going to lose at the very minimum the forefoot and probably much more of the lower limb. They may well end up with a below knee amputation. This doesn't look quite so dramatic in many ways, but is actually a worse problem because you can see the swelling of the foot, you can see the pus underlying this ulcer. And this is a polymicrobial infection. It's a grade 5 ulcer, which means it affects the hindfoot. And these have a very poor prognosis. And this may be the patient who goes on to develop gas gangrene, becomes toxic, and needs an acute below knee amputation. I'm glad to say that's a pretty rare situation, but something one sometimes finds oneself in line for. It always happens at the most inconvenient time when you're most exposed. But these patients need urgent care and clearing of the infection, and that may well require a below knee amputation to save their life. So this is Brodsky's classification. So you go from at risk through to superficial to deep osteomyelitis. And then he classified A, B, C with gangrene, partial foot, or ischemia without gangrene. So as I've said before, this is a clinical thing, and one needs to look at it clinically. And really, I've got most of the information I need, having seen the patient and looked at the radiographs. The laboratory tests are helpful. I don't frankly find MRI that helpful. That's to secure things. But I really don't think in these patients with the acute red septic foot, they need to delay surgery for drainage of pus for an MRI or an ultrasound. That's procrastination, it's uncertainty. But really what they need is acute surgical debridement and draining of the pus. And I would encourage you to be brave and drain the pus rather than timid and wait 48 hours when they get sicker and book scans, because the scans often are unimpressive and not very helpful. Most of this is about the swinging fever, the flushed looking patient, and the clinical appearance. The foot looks tense and unpleasant. Radiographs are very helpful. This is the patient I showed you earlier, and you can see he's destroyed the 5th metatarsal. He ended up with a 5th ray amputation. If you look at the texts on MRI scan, really it's a clinical thing. So, you know, if you look at what they're saying, often the MRI reports that you've got an ulcer that goes down to bone and such like. And actually, I don't find MRI that helpful. It can be useful in the subtler cases of edema, in large collections, but you don't really need this. So that, you know, they're just whilst NICE are very keen that you get an MRI scan on all of these patients. Sometimes in these patients, what it needs is clinical action and surgery, not procrastination. So I think one of the things that always worries people is the foot adequately vascularized. Now, when one's coming to semi-elective treatment of these patients, maybe with a Charcot or osteomyelitis, a non-critical patient, it's important to reconstruct and optimize the vascular status of the foot before going on. So if you're going to do a ray amputation, you want to have the circulation as good as possible so that your amputation heals and everything goes well. There is often a question, and it is often difficult to know in a big swollen foot which has an abscess as to whether the pulses are present. You can't feel them and so on. I would encourage you, hopefully you'll have a sufficiently robust hub and spoke vascular structure that you can get advice. But if you can't, I think it's perfectly acceptable to go ahead and drain the pus. Okay, the wound may not heal, they may need to go on to a further, a higher amputation, but that was probably going to happen anyway. And I think the mistake is to sit, wait, observe, and then when the patient gets really sick, you're in a much more difficult position because they then have spreading septicemia. So it is about early assessment. Hopefully you can get some vascular input, but if you cannot, I would encourage you to drain the pus because it's not really going to take things back. It will probably take them forward. Okay. Grade 1 ulcers, don't forget total contact casting, but we're not really talking about that tonight. Many of the simple ulcers can be healed simply. Now, it's when we get to the deeper ulcers that we get onto the surgical side of things more so. So when you have osteomyelitis, you can try antibiotics, and they're effective in about 50%. But with the deeper osteomyelitic foot, you may well have unreconstructible disease, as the patient with the 5th metatarsal had. And those patients are either going to end up with a debridement and maybe implantation of some sort of carrier with antibiotics in, or amputations. What you want to have at the end of this is a functional foot, okay? Often I see feet which have had random amputations and look like they've had a shark bite. That's not going to work. You need to have a good reconstructed foot. You don't want open wounds that are going to be left to granulate for days and days. So if you're going to do the amputation, and I know this doesn't quite come into the topic of this, but it's something that I think is really important. If you're going to do it, try and do it under local anesthetic. These patients often have other diseases. When you're doing it, preserve all the skin, then treat the infection like tumor, excise it, try not to get into the sepsis, into the infected areas, try not to spread that through. Create full thickness flaps, be very gentle with your soft tissue handling, and close loosely. And with that, you can often primarily close. So this is a patient who for many years had or not for many years, but for many months had an ulcer under the 1st metatarsal head. We tried to treat it, it had not settled because they had septic arthritis of the 1st metatarsal phalangeal joint, and that often won't settle because of the continuous efflux of the joint fluid. And he got destruction of the 1st metatarsal head. And what we did with this was a ray amputation, and there's the base of the 1st metatarsal. But you can see we've elevated the full thickness flaps over the extensor and the flexor tendon, excised the infection en bloc. So this is the infected joint, which I've not opened. And then we've washed it out and primarily closed it. And actually, that patient goes on to heal. So we published this in the BJJ. There is no doubt that many of these patients do much better. And these are feet at 2 weeks, which have undergone amputation. So you can see this is a brewer, and he'd trodden on something in the brewery, and he had osteomyelitis 4th metatarsal. We took a ray and closed that. And here is a patient, I don't think it is the same patient as I showed earlier. But if you close the wounds, they go on, they don't need insoles and shoes. But if you can do that acutely, it does make a huge difference. Because believe me, if you leave these things open, they take months to heal. And it can't be sensible, surely, to have a bone at the base of an open wound that may well get infected. So pus needs urgent drainage, okay? And how do you tell that patient? It's difficult. They're not quite as obvious as you'd think. It's a little bit like that web space infection in the hand, but it's more difficult because they're neuropathic. The patient with infection in their hand has extreme pain and is very uncomfortable. These patients are neuropathic. They will have pain and they'll have a tense foot, but they just look uncomfortable. And that's partly, I think, the septicemia, partly the systemic infection, but partly, they have a high level of pain. The tissue is under tension, and even with their neuropathy, the pains come through. So I will always ask to look at the numbers. So look at the full blood count, but particularly look at the CRP. And if that's not settling after, they've often had antibiotics for a day or two intravenously before you're called. And if their CRP has stayed up over 100, 200, they can be very, very high. Just think, okay, antibiotics aren't working. Do I need to stick a knife in this? And you often will. Act, do not delay. Don't wait for Monday. You'll never be criticized for rushing in early. So how do I drain the abscess? What are the principles? Well, here's one I did earlier. And you can see that there was a large abscess around the base of the fifth metatarsal. You can see how injected and thickened and edematous that foot looks. It's slightly bluish. You often get secondary venous and digital arteritis, septic digital arteritis, and that causes secondary gangrene. This patient hasn't quite got that, but is getting there with some venous congestion. So make big incisions, make them along the line of the tendons. Usually the pus tracks along the line of the tendons. So you'll see in the next patient, we follow the flexor tendons. But don't be afraid to make broad incisions. I've almost isolated that fifth toe, but there was pus to both sides of it. And I think it's really important to drain that. Often it's just a relief of tension, actually breaking down the septa within the web space. So in fact, you don't get a pleasing gush of pus often, but don't be disappointed in that. You've done the patient a huge favor. And in these patients, that you've got to leave them open and let things settle. Here's another one. This was much more impressive. This is a big pussy foot, very sick patient. You can see the previous ulcer just over the tip of over the interphalangeal joint of the great toe. And this is a patient who didn't get on and get treated, but carried on. So in this one, there was pus, and obviously he was very unwell. And in this, I undertook the incision. You can see the incision, you can see the free flow of pus. And you can see how we followed up the flexor tendon, and I think that was the flexor hallucis longus, which was ruptured and infected. And because there was deep infection, I did a first ray amputation at the same time. Now that's not necessarily something you should do. You're quite justified. If you're not happy doing that, just draining the pus. But please drain the pus, and somebody can go back later. The important thing is not to take away too much skin or be too aggressive, because then reconstruction becomes much more difficult. So you can see here, I followed the line of the flexor tendon, and you can see how that has drained the pus, and this foot immediately looks a lot happier. And you can see how the vascularity, it's not just a tourniquet, is improved because the lack of tension in soft tissues. So one of the differentials, and Venu is going to talk about this next week, is Charcot joints. Okay, so I've seen Charcot joints from all over, from neurologists, from specialists, which have not been diagnosed. Sorry. So diabetes is now the leading, it used to be syphilis, it's now diabetes is the leading cause. So you can see this patient, okay? You can see the obvious abnormality of his right foot. So one of the things Jim Brodsky taught me when I worked with him was if there's no break in the skin, it's extremely unlikely that there's infection. So this patient will often have a temperature, may have a raised CRP, has certainly got a red, hot, swollen foot, but there's no ulcer. Now, if you're telling me that that leg is infected, that foot is infected, what you're saying is there's been hematogenous spread. That is extremely rare. So these patients tend to have good circulation. They don't tend to have infection. So if there's no break in the skin, it's much more likely to be Charcot than it is to be an abscess. So that's how you make the diagnosis. The plan with Charcot is to hold the foot shape. Sometimes they present later with ulceration infection, and then you may get into the problem of secondary infections around that. So that's the time that they develop it. So it's not the acute red, hot, swollen foot without any break in the skin where these patients get abscesses and infections. It's the later presentation where they've already ulcerated because of the abnormality of the foot shape. Sometimes you can just make an incision and you can just take off. If they've got a rocker bottom foot, you can do an exostectomy. So here's a lateral where the cuboid is subluxed down, and you, by incising across that and flattening the bottom of the foot, particularly on the medial side, which is about 94% successful, as opposed to the lateral side, which is less successful. Simply doing that will actually cure the patient's problem. They become curable with a total contact insole and a plaster. Sometimes one has to do more, and this is a patient I saw early in my career, and I reconstructed her, and she died with a foot that was healed and intact, and you can see where the ulcer was. Okay, but she had a flat sole of her foot, and she could walk on it without ulcerating. Here's an AP of the guy's foot and a lateral of his tibia. So this is a patient with ankle problems, and he dislocated, and he had bilateral problems, and he needed a nail. Venu will talk to you about this next week. Now, this is a different problem. This is a patient who'd had previous surgery. She was diabetic, it had been closed. Obviously a little bit timid from the initial surgeon because he was concerned that he was going to cause infection. So she had a percutaneous fixation, which probably didn't work. But when one sees a problem like this, and you can see in the lateral how this is all beginning to fall to pieces, it may be a Charcot, but the patient's had an open operation. So one has to be considering whether there is infection present in this. And this lady went on to fall to pieces like that. She ulcerated where that fibula is, and she ended up with that wound. And you can see we've excised the fibula and put a frame on her. So as soon as you start to open the skin, then what may be a Charcot may well not be a Charcot, may turn into infection. So just remember that rule. There's no break in the skin. It's much more likely to be Charcot. Now, the other sort of foot attack we see a lot of is ankle fractures and foot fractures in diabetics. Okay, these are poisonous and they can be very difficult. It's not something we talk about very much, but it's so important. So this is a patient who was referred to me. She'd come into A&E about, I think it was about 8 weeks earlier, and those were x-rays. Now, even with the retrospectoscope, if you look at that, it's very difficult to see any fractures. That's how she presented to me 8 weeks later. So she'd had trauma to her ankle, minor trauma, an ankle sprain. Probably if you'd CT'd it, you'd have probably seen some small cracks. But she developed a Charcot ankle and the ankle fell to pieces. So if you see a patient with diabetes who's neuropathic and can't feel the 10-gram Semmes-Weinstein monofilament, it's no tragedy to put them in a plaster and just let things settle down if you're concerned. So one of the things that worries me is this. So this is a patient who'd had an ankle fracture. You can see there's a medial wound. There's a little bit of lack of conviction. There's a wire there. There's a wire in the medial malleolus, or is it 2 wires? And there's this pin, this Steinmann pin has been put in through a heel. Is this the right way forward? Unfortunately not. And this guy ended up losing his foot because unfortunately infection got in around the heel pin and caused him trouble. So how do we treat these patients? So one has to accept that if one treats ankle fractures in diabetics, you're going to have a higher rate of complications. So in the control group, 2%, in the diabetics, 30% major complications, 10% amputations. So ankle fractures or major foot fractures in diabetics are poisonous and lead to amputation. What we would need to try and do is minimize that. And I think this is a very small study, but in this, there are 6 patients who were treated in cast. All 4 unstable fractures ulcerated and 2 out of 6 went into non-union. The operative patients, 4 out of 19 got infected, but all healed. So is it that fixing these patients and being a little bit brave once again has prevented worse problems? So I'd be disappointed if I had a 20% infection rate in ankle fractures, major infection rate in ankle fractures. But if you look at the alternative, which is ulceration in 4 of the ankle, or 4 of 6, and all of the unstable, treating these patients with neuropathy is disastrous. And believe me, once they ulcerate, it becomes a very difficult situation to salvage. And one often is either looking at a frame or more commonly an amputation. So you have to accept that in diabetics, infection and problems are commoner than in non-diabetics. So watch the bog standard fracture in a diabetic, warn the patient, and it was something that I was taught by Jim Brodsky, double the immobilization time. I don't know quite why that is. There's no real research. It's just that fracture healing is delayed in diabetics. So a straightforward ankle fracture is in a plaster for 3 months. A bad ankle fracture is in plaster for 6 months in my clinic. And be aggressive. Fix them and accept your higher complication rates. Preoperatively counsel the patients appropriately, but accept that. So the red, hot, swollen foot, cellulitis, pus, and Charcot. You need to act on this. This is not something that you can wait for the foot and ankle specialist to come back to. Hopefully I have shifted some of your fear. Make sure you evaluate particularly the circulation and the neurology and document it. And if you may well be critical, certainly in saving a limb and even a life in these patients. Thank you very much.
Thank you very much, Fred. That was fantastic talk. The two key messages that came out from your talk for me when dealing with a patient with an acute hot swollen foot is really that initial clinical, really high quality clinical assessment, and really asking the question, how has this ulcer actually occurred? Because not all ulcers are the same. And you gave a very good example of that lady with the septic arthritis of the first MTPJ that needed extensive debridement. And the other thing that came out is exactly what you said at the end. These patients have a life-threatening condition, so they are an absolute priority. Our priority is to save their life first and ask questions later, essentially. So don't procrastinate, don't wait for the MRI scan or ultrasound scan, don't use that excuse. You need to treat the patient as sepsis and get in there, get into theatre, drain the pus, and then deal with what to do after that. So that came across really, really clear. That's fantastic. I just want to focus on the clinical assessment side of things, because I've had a rather interesting question actually, which relates to identifying infection in patients of dark skin color. Do you have any tips and tricks? Because it is more difficult to see the erythema in dark-skinned individuals. So, how do you make that assessment in those patients?
I think it's a very fair question. It is difficult. I think often you will see the pus lying under the skin, and that's very clear. I think it's the tension in the soft tissues are crucial. I mean, the erythema is not so easy to observe. I completely accept that. But it's about the systemic assessment of the patient. And one can look at the foot, but I think one of the things is it's sometimes a little bit confusing, whatever the skin color, because actually the foot is not so swollen. It doesn't look quite as angry as it should. And it's the fact the patient's jumping around the bed and looking uncomfortable. And I always say, can we look at the numbers? And, the CRP is persistently high. They've got a swinging fever. It's all that clinical stuff. So be a little bit cautious just looking at the foot. And I think the skin color, I completely accept it is more difficult in dark colored skin. But actually, a lot of it is really about looking systemically at the patient and appreciating, their general illness, and looking at the patterns and seeing the swinging fever that's been going on despite intravenous antibiotics, the CRP that's persistently raised, the fact they're still complaining of pain and saying this is agony. Those are the keys, I think, that you need to really pick up on and go, okay, this is not working. What can we change? And often the change is drainage.
Thank you very much, Fred. Just sort of going to so let's take, for example, this sort of septic patient that you described. So let's hypothetically speaking, they've got a CRP of 350, they've got an elevated white count of 18, they're systemically unwell in themselves. In your Cambridge unit, how do you treat them? In other words, what categorization would you put? So assuming the patient comes in during the day, is this something to be done literally in the middle of the night type of operation? Or is it, can you pass a judgment and then decide to wait till the next day? What priority do you set on these patients?
I mean, the priority is high and they need to be done within 24 hours, I would say. I mean, these will not be simple patients. They often have multiple comorbidities. They've often got renal disease. So we're very lucky. We've got Tony Cole is the diabetologist I work with, and he admits these patients. The systemic optimization of them as much as you can is very important. But if they're collapsing with sepsis, you need to get onto it. You need to get the anaesthetist to see them. You need to resuscitate them. And you need to get them down to theatre as fast as you can. So I think, honestly, I wouldn't do them in the middle of the night at 2 o'clock, but I would probably do them at 8 o'clock in the evening, or certainly not put them first on the trauma list the next day. Unfortunately, what I often see, I don't know what it's like where you are, Hero, is that the patients often are left for 48, 72 hours because there's a great reluctance to people are busy. There's fractured nexus femur with, incentives to operate, financial incentives and so on and so forth. And they tend to get priority. I think that's a big, big mistake. These patients are really sick and they need acute drainage. Otherwise, they're going to end up systemically unwell, malnourished, ITU and all of that.
Yeah, I agree, Fred. I mean, certainly in our unit, what we're trying to sort of promote is, this is a general surgical emergency essentially for us essentially. So don't wait until the local foot and ankle surgeon comes along a couple of days later. Don't wait for them and just say, we've organized an MRI scan and what do you think? Treat that patient. It doesn't have to necessarily be the middle of the night, because that in itself raises complications of operating in the middle of the night. And I think we have to take that into account. But certainly I agree, within 24 hours is a reasonable sort of time frame on the next available trauma list.
Yeah.
You mentioned rather interesting thing where you showed the debridement under local anesthetic. Was that local infiltration, or were you talking about regional anesthesia? Because from the anesthetic perspective, if you've got a sick diabetic patient, putting them to sleep or giving them a spinal is probably not a great thing that they're keen on doing.
Okay, so you mean the ray amputation?
Yes.
I mean, I think you can. It's tricky doing that under pure midfoot block or something. I work with a very good anaesthetist, and he'll often put in a popliteal block or something similar. I'm very relieved to see a good musculoskeletal anaesthetist arrive, because these patients are extremely unwell systemically, I often get, when one's doing these cases and one has a less an anaesthetist who's less aware, he's probably going, good God, what are you serving up? Because these patients are really unwell. They're very complex, and they have got vascular disease. Often many of them have got small bowel transplants with pancreas and a whole lot. It's very, very difficult. And actually, if you can do them under a regional block and a popliteal block, that's very good. The minor stuff you can do under pure local. Somehow I find that patients with neuropathy are extremely susceptible to local anesthetic. So a little bit of local goes an awfully long way, and you get a really very good block just from putting some local into the foot, actually, or doing your own ankle block. But it's much nicer if you've got an experienced musculoskeletal anaesthetist who can do that for you.
Yeah. Well, one wonders whether it's a bit of homeopathic local anesthetic around the area. I've got an interesting question here, and they ask, are there any circumstances where you've been able to carry out amputation, small level amputations or debridements without any local at all? What's your experience there?
I mean, I do quite a lot of amputations under local. I think you do. I put some local in. I put 20 mils of 0.5% Chirocane, because one does. I mean, as I said, it's extremely effective. You probably could, but it just seems a bit unkind, and I think they probably would feel something. So, one of the things I think that's the point that's worth making is often I would try and do this surgery under tourniquet. And it is remarkable. So you start out under tourniquet, and suddenly you realize it's all going horribly wrong. And there's just a blue surge of blood at you. And the secret in that time is to let the tourniquet down, because these patients have really, really severe calcification of the arteries. So the tourniquet, unless you ramp the pressure up to God only knows what, will not compress that. And you're much better off going, okay, I'm defeated. I usually start with a tourniquet. But if it's doing that, just let the tourniquet down, and what you'll find is the venous occlusion releases, and you'll get fresh arterial bleeding. Maybe not so much of it, but it's a much easier environment to work in than just having venous blood coming at you because you've got a venous tourniquet.
Yeah, I think I'll do much the same, is apply the tourniquet and see how it goes.
Yeah.
But release it as a drop of a hat if it's not working, essentially, due to the calcified vessels. I think that's reasonable. One of the questions really here relates to planning of your incision for the debridement. So with a hot swollen foot, let's say there's some necrotic skin and necrotic tendons. You mentioned that you'd make your incision longitudinally along the line of the tendons, but when it's not so clear, how do you plan your incisions when you've got quite extensive necrosis and skin breakdown? How do you plan your incisions there?
I think you've got a couple of groups of patients, really. You've got patients with vascular disease who tend not to be so florid with their abscess. I think just that there's not so much blood, so they don't have so many white cells getting down there. Those tend to be the patients who get the secondary arteritis at a drop of a hat, and they end up with a necrosis. So they get an infection, they get an abscess, and then they get secondary infected arteritis, and then they occlude the digital arteries, and the toes start going black one after another. And unless you get in there and release that very early, that will progress on, and you'll get left with almost nothing. You just have a black forefoot that you've really got no salvage with, and you have to get on and do a below-knee amputation. So in those patients, I think the important thing is to decompress it. I'm honestly not so bothered. What I find sometimes is, and it's particularly the plastic surgeons, are so radical with their debridements. One ends up with a great big hole. And then you say, well, okay, how are we going to fill that? And they can't. So actually, from my point of view, I like to get the pus drained and decompressed, but I'm a little bit timid sometimes about taking away the skin, because if you can close the wound, it absolutely transforms the care of these patients. If you go back to the plastic surgeon and say, okay, well, guys, you've taken away, the skin on the sole of the foot, can you resurface it? They go, oh, no, I can't do that. And you're in this sort of, you're robbing Peter to pay Paul. You've really got to try and preserve as much skin as possible. Some skin is often questionably viable at the time of the original surgery. From a personal point of view, and I know it doesn't quite go with the ethos of open fractures and so on, but actually I'd probably rather keep that, so that when I can see how it turns out. And then I feel I've usually got the experience, and it doesn't really affect me too much. But I think if you're less experienced, I would probably not just cut away everything. Give it the benefit of the doubt, and then somebody with more experience is going to go back in 24, 48, 72 hours, and hopefully at that stage things will be clearer.
Yeah, I agree. There's a suggestion here, actually. What about, so when you're not really sure where the bag of pus is, because ultimately that is what it's about, isn't it? It's about releasing the pressure. You're not necessarily doing a complete debridement in the first operation. That can be done as a secondary procedure, and often will be done by a foot and ankle surgeon as a secondary procedure. What about the role of getting a wide bore needle and aspirating to see if you can localize the collection, to give you a better idea of where that collection might be? So, for example, you gave that example of that lady with the first MTPJ. That collection may be all the way up into her midfoot somewhere. And if you're not sure about where to go, what do you think about the role of putting a needle in and just seeing if you can aspirate something out and then targeting that way?
I mean, I think that's a bit dangerous, actually. I mean, often, that in that case, it's pretty obvious what's going on because you've got lots of pus. The one that worries me more is where you've got pus in the web space. It's between the toes, where actually when you get up and open that, you get little beads of pus. You go in and aspirate that, you'll get nothing out. And they're the ones that are really uncomfortable, and they're the ones that progress on with the digital thromboangiitis and so on and so forth. I don't, when you've got lots of pus and it's pouring out as it is with that ray, I don't think you know where to go. It's the ones where you don't know where to go are the ones usually in the web spaces, and then you just need to stick a knife in there and decompress them. And as soon as you release the tension in that, it's extraordinary how the circulation improves and the whole foot decompresses. It's the same in the hand, as I remember it.
Yeah, it might give you that false sense of security that you've actually stuck a needle in or didn't get anything out. And often that is the case, isn't it? You stick a wide bore needle in, even though there's a collection there, it's just so it's such thick sort of material that you cannot aspirate it out. Yeah, that's great.
I think ultrasound, MRI, all of these things on the whole underplay it. If you've got a big collection, you can see an ultrasound, that is a really big collection. It's the smaller collections which are less clear. And that's why I think you have to go clinically and less by the investigations.
Let's talk dressings then. So post-op, you've done that debridement, that patient that you've opened up that around that fifth ray, that's not going to close. No, so you've got exposed tendons there. So what do you dress with? What's your sort of general policy for unclosable wound?
So I'll give it a good wash out. I think that's really important to wash everything out. I'm an Inidine man. I just use Inidine on everything. Actually, to be honest, Inidine, dressing gauze, Velband, and put it in a plaster. I think what you need to do is rest it. So I don't know, I'm not terribly fussy. I mean, I just use Inidine for everything, frankly. I mean, there's lots of things you can use. You can use amniotic membrane, you can use, whatever you want to use. Actually, I think the important thing is to clean it well and then to keep it moist, elevated, and appropriate antibiotics. And it is remarkable, I know that you're not supposed to, skin is not supposed to heal over tendons, but it does. You get granulation coming through the tendon, And actually, it's remarkable how those wounds will heal. I can't remember what happened with that one that I showed with the incision around the fifth ray. I really can't remember, but often they will just settle down. One just leaves it and let things resolve. It's going to take time, but if you give it time, your patient, you'll find it settles.
Yeah. I just wanted to ask a question with regards to something you didn't mention, and if it's not relevant to this particular talk, then please say so. But the use of antibiotic-loaded calcium phosphate beads. I mean, there are two main manufacturers that we can use that will allow you to apply antibiotics locally to wounds and cavities. And so, is that something that you use at all?
It's not something I use, but I mean, I've used a couple of times just to eliminate myself. I don't have any financial disclosures. I know to say that, but I really don't. So I thought part-time, a lot of part-time because it's also something that they take out polymer with you can use that to hack. I hack these other agents, but my problem is if you take out the metatarsal head, you largely defunction the ray. So I think one can often spend a long time preserving things without actually preserving function. Having said that, I think it's one of the things that has moved a lot over the last 5 years. And I think one can be more
Fred, I think I better stop you there because I think we've lost your sound. So you can go yes, maybe, no to the calcium phosphate antibiotic loaded sort of material. Can you?
Is that better?
No, I think we're losing your sound, but we are coming towards the end of the session anyway. If we can, there is actually one very good question which relates to your ankle fracture, and maybe you can sort of use hand gestures and so forth to try and sort of mitigate the sort of sound loss. You mentioned double immobilization for diabetic ankle fractures. Is that for all patients with diabetes, or is that for a subset of diabetic patients that you would be particularly concerned about?
Particularly about the ones who can't fit 10 grams and sometimes one of them.
Yeah, so basically it's the identified neuropathic patients who are severely at risk, and those are the patients that you would take extra caution on. But just because they've got diabetes on their medical history and a bit of metformin doesn't necessarily put them at risk. Yeah, great. Well, on behalf of BOFAS, I would like to thank you, Fred, for an amazing evening's education. The IT committee and Joe Millard have been in the background, and so they've been really busy, and I'd like to thank them as well. And also Tim Williams from the education committee. I'd like to remind you that the attendance certificates for the CPDs will be issued following completion of your feedback. So as usual, you're going to receive an email within the next 24 hours of logging out. If you don't receive it, then please use any previous link, and Joe has put the code in the Zoom chat. So just make a copy of the Zoom chat code so that you can get the CPD for this particular session. So we look forward to seeing you at the next week's episode, which is the second installment of the Diabetic Foot series. And that's going to be same time next week on Monday. Good night, everybody.
You spend years of orthopaedic training to become masters of surgery. Do you want your surgery to be compromised by poor post-operative pillow elevation? There is another way. OrthoLove elevators can be used before, during and after ankle surgery to help contribute to a better outcome. Before surgery, get the patient swelling down and speed up time to theatres. During surgery, ditch the upside-down kidney dish and use the OrthoLove foot holder to keep the limb in the correct position throughout your case. After surgery, cradle the limb with comfort and stability above the level of the heart to reduce post-operative swelling, enhance wound healing, and soft tissue recovery. But what about when the patient goes home? Ortholove home foam elevators are beautifully designed and much loved by our patients. Celebrities and professional sports stars all raving about us on social media. Ortholove is proud to support the BOFAS commitment to training and education.